Hello guys, today we'll be talking about amoebiasis and we'll be talking about amoebiasis under the following headings: introduction, causative agents, pathogenesis, epidemiology, risk factors, diagnosis, prevention and control, as well as treatment. What is amoebiasis? Amoebiasis is a parasitic infection that is caused by entamoeba histolytica, an anaerobic protozoan parasite that colonizes the human gastrointestinal tract. Amoebiasis remains a major public health problem, particularly in regions where sanitation and access to clean drinking water is inadequate. Amoebiasis ranges from asymptomatic intestinal colonization to severe and life-threatening disease such as amoebic dysentery and extra-intestinal manifestations, including amoebic liver abscesses. Globally, millions of persons get infected annually, and the disease is strongly associated with poor sanitation as well as collapse in public health infrastructure and poor accessibility to safe drinking water. Clinically, amoebiasis is very important because its symptoms mimic that of other gastrointestinal disorders such as inflammatory bowel disease, bacterial dysentery, as well as colorectal cancer. Misdiagnosis is very terrible because it can lead to inaccurate therapy and treatment, as well as severe and fatal complications. Understanding the epidemiology, pathogenesis, diagnosis, and control of amoebiasis plays important role in effective clinical management of the condition. Let's talk about the causative agent. The causative agent of amoebiasis is entamoeba histolytica. The causative agent of amoebiasis is entamoeba histolytica. Entamoeba histolytica is the causative agent of amoebiasis. It is a unicellular protozoan parasite that belongs to the phylum Amoebazoa. It belongs to the phylum Amoebazoa. Entamoeba histolytica has two major morphological forms, which includes the cyst and the trophozoite. Cyst and trophozoite. The cyst and trophozoite are the two morphological forms in which entamoeba histolytica exists. The trophozoite looks like this, where you have the podium, then you have irisum, nucleus, then uh, ingested RBC. This is how the trophozoite looks like, just to label a few. And then the cyst, round, you have nuclear, then carriosome. Is the chromatoidal, is the chromatoidal body. Is the cyst. So this is the trophozoite, and this is the cyst. Just to label a few. The trophozoite is the active as well as the motile and feeding form of the parasite. It measures about 15 to 30 micrometer in diameter, and it uses the pseudopodium for movement. It uses the pseudopodium for motility. The trophozoite resides primarily in the large intestine, where it multiplies by binary fission. Trophozoite is fragile, and as such, it cannot survive without the host, making it to be non-infective outside non-effective in the external environment. Trophozoite is non-infective in the outside environment. The cyst, on the other hand, the cyst is the infective form of Entamoeba histolytica. It is the infective form of the parasite. Mature cysts are usually spherical. They are spherical and they measure about 10 to 15 micrometer in diameter, and they have four nuclei. Very important, they have four nuclei. The cysts are highly resistant to harsh environmental conditions, and they can survive for weeks in moist soil, water, and food contaminated with feces. Transmission of amoebiasis is basically through ingestion of mature cysts. It's also very important to note that there are other species of Entamoeba that are morphologically identical and similar to Entamoeba histolytica. Some of these species include some of these species that are morphologically similar and identical to Entamoeba histolytica include some of these species include Entamoeba dispar, also Entamoeba moshkovsky and Entamoeba bangladeshi. These species, Entamoeba dispar, Entamoeba moshkovsky, and Entamoeba bangladeshi, are morphologically similar and distinct and identical rather to Entamoeba histolytica when examined under the light microscope. But it is important to note that only Entamoeba histolytica has been confirmed and verified to be the causative agent of amoebiasis. The pathogenesis of these other species is still a subject of debate. Let's talk about the pathogenesis of amoebiasis. Infection of amoebiasis usually begins due to ingestion of matured cysts of Entamoeba histolytica through contaminated food or water. The cyst is able to survive this acidic nature of the stomach, making it to penetrate into the small intestine. In the small intestine, excistation occurs. Excistation. Excistation occurs in the small intestine. Excistation is a biological process whereby a mature cyst breaks open, releasing free motile trophozoite, and this usually occurs in favorable environmental condition. The cyst, the trophozoite, once released in the small intestine, migrates to the large intestine where it adheres to colonic mucosa. Also, it is important to note that in most infected individuals, the trophozoites remain confined within the intestinal lumen, causing no symptoms. However, in invasive disease, the trophozoite adhere and degrade the intestinal epithelial cells of the intestinal tract using surface lectins, particularly the N-acetyl D-galactosamine lectin. Trophozoites use surface lectins to degrade the intestinal epithelial cells, particularly the N-acetyl-D-galactosamine lectin. And it's also important to note that adhesion of the trophozoite to the intestinal epithelial cells help the trophozoite to resist being flushed away by peristalsis and mucus. Trophozoites also release cytotoxic substances such as proteolytic enzymes, phospholipases, and amoebospores. And these cytotoxic substances, when released, induce apoptosis, programmed cell death, and necrosis. And this eventually leads to formation of ulcers. These ulcers coalesce, culminating and leading to extensive mucosal damage, bleeding, and secondary bacterial infection, which manifests clinically as amoebic dysentery. Sometimes, in some cases, trophozoites also penetrate into the bloodstream through the portal circulation. Once in the bloodstream, trophozoites invade the liver, causing hepatocellular necrosis, which eventually leads to amoebic liver abscesses. In rare cases, trophozoite can invade the brain, the lungs, and some other organs, causing severe and fatal complications. This is basically the pathogenesis of amoebiasis. Let's talk about the epidemiology of amoebiasis. Amoebiasis has a worldwide distribution, and it is particularly predominant in tropical as well as subtropical regions. Globally, hundreds of millions of people get infected, and tens of hundreds and tens of thousands of deaths occur annually due to invasive disease. High burden regions include parts of Africa, Asia, Latin America, and the Indian subcontinent. The disease amoebiasis is strongly associated with poor sanitation, overcrowding, and poor accessibility to safe drinking water. In endemic regions, transmission is usually continuous and it often occurs in childhood. In developed countries, amoebiasis is relatively uncommon. It is only usually seen in immigrants or travelers from endemic regions, institutionalized individuals, and men having sexual intercourse with fellow men. Outbreaks may occur due to contamination of water supply sources and food sources. The disease shows seasonal variation in some regions with higher incidences during rainy season due to increased contamination of water sources. Let's talk about risk factors. Certain risk factors predispose an individual to acquiring amoebiasis or coming down with invasive disease of amoebiasis. Such risk factors include one, poor hygiene practices, such as inadequate hand washing after defecation or before food consumption and preparation. Also, consumption of untreated water or vegetables that are washed with untreated water. Also very important as a risk factor is immunocompromised conditions. Immunocompromised conditions such as HIV predispose to infection generally and also amoebiasis as well. Socioeconomic or socioeconomic conditions such as poverty, such as living in overcrowded regions, as well as inadequate sanitation facilities predisposed to coming down with amoebiasis. Chronic alcoholism is also a very big risk factor, particularly predisposing and making individuals susceptible to amoebic liver abscesses. Let's talk about diagnosis. The diagnosis of amoebiasis is based on clinical evaluation, laboratory confirmation and investigation, as well as imaging studies. Clinically, symptoms such as bloody diarrhea, abdominal pains, tenesmus, and weight loss may trigger suspicion, particularly in patients in endemic regions. Microscopic examination of stool samples is the traditional mechanism for detecting cysts and trophozoites of the entamoeba histolytical parasite. Multiple stool specimens are usually used to improve and increase the chances of detection. However, this method has limited sensitivity and specificity and cannot reliably distinguish between Entamoeba histolytica and non-pathogenic species such as Entamoeba dispar, Entamoeba moshkovsky, and Entamoeba bangladeshi. Polymerase chain reaction as well as other molecular techniques offer improved accuracy, precision, sensitivity, and specificity because they detect the genes and the DNA specific sequences of the Entamoeba histolytical parasites. Serological techniques are also very important as they help detect antibodies against the parasite. Imaging studies such as ultrasound and computerized tomography scans are used to detect amoebic liver abscesses, assessing its size as well as location. Let's talk about prevention and control. Prevention and control of amoebiasis relies on improving sanitation and hygiene, provision of safe drinking water sources, proper sewage disposal, and effective waste management. Very important. Also, food safety measures should be employed, such as thorough washing and cooking of fruits and vegetables before consumption. Also very important is health education and community awareness. This plays important role because it helps reduce risky behaviors and reduces susceptibility to community spread of amoebiasis through knowledge and informed decisions by community members. There is no effective vaccination for or against entamoeba histolytica, and as such, preventive strategy is generally based on environmental and behavioral interventions. Let's talk about treatment. The treatment of amoebiasis depends on whether the infection is asymptomatic, intestinal, or extra-intestinal. Asymptomatic carriers of entamoeba histolytica are usually treated to eliminate cyst carriage and to prevent transmission. To achieve this, luminal amoebocytes are used. Luminal amoebocytes are used to eliminate cyst carriage and to prevent transmission of cyst. Examples of these luminal amoebocytes include examples of luminal amoebocytes include the paromomycin, also dilozanide fullrate, as well as iodoquinone. Examples of important luminal amoebocytes that are used in treating asymptomatic amoebiasis in order to eliminate cyst carriage as well as prevention of transmission. Examples of those luminal amoebocytes include paromomycin, dilozanide fullrate, as well as iodoquinone. These are the most common. Symptomatic amoebiasis is usually treated using metronidazole, metronidazole or tinidazole. Asymptomatic, no, symptomatic amoebiasis rather is usually treated using metronidazole or tinidazole. These agents are highly effective and efficient when it comes to elimination of trophozoites. Trophozoite elimination is done using metronidazole or tinidazole. Then treatment is followed by use of luminal amoebicides to eliminate residual cysts. Amoebic liver abscesses is usually treated using metronidazole alone. So this is basically the treatment of amoebiasis.